Hi, it's Dr. Janet Pope. I'm reporting at EULAR 2025 in Barcelona. This is part of our great At Room Now series. I'm going to talk about osteoarthritis with a few abstracts on maybe helping to find some positive studies. So the first was a poster 0492. This was really interesting. There was a single intra-articular injection of gene therapy of a product called PCRX-201. And it was used in moderate to severe symptomatic knee osteoarthritis. Had to have symptoms, it had to be X-ray proven. It was one injection and there was no placebo, but they tested a few doses. So it was an early phase 1, so no control group. And what this was presenting was that there was still WOMAC improvement out to greater than 104 weeks, so up to greater than 2 years. And for some of the higher doses, even close to 3 years, there was still benefit. So this space is very interesting. It looked like so far it was safe, but it really will have to have a RCT comparison group, double blind, and all the usual ways to get something like this to market, but pretty exciting. Now, the other two posters are more a little bit about what we can learn from where we've been and how we can maybe improve trial design. So the next was poster 0565. It was a systematic literature review of how we have borrowed treatment of other drugs for other indications in osteoarthritis. And as rheumatologists, we're used to that. Methotrexate, our drug that is our anchor in rheumatoid arthritis, was borrowed from cancer. We've borrowed drugs now that the dermatologists have had positive studies that have then gone into RA, etc. But in this systematic literature review, there were multiple drugs, and in general, no surprise they didn't work. So as for instance, methotrexate had some positive and negative clinical trial data. Colchicine, IL-1 inhibitors, TNF inhibitors, bisphosphonates, vitamin D, estrogens, and other hormone replacement therapy were mostly negative with the odd positive small study to boot. We've also had issues with the nerve growth factors that were actually developed to try to change osteoarthritis and symptoms, but also to be a disease-modifying drug. And as you all know, this class of drugs at the end of phase 3 found rapid progression of OA in some patients, not many. It might or might not have been a D mode, but even the effect wore off on pain over time, as it often does, because pain can flare and improve in patients. And also, there was some nerve damage, peripheral neuropathy, so that never came to market. So with that being kind of discouraging data, poster 0612 was trying to predict treatment responses in knee osteoarthritis that was symptomatic. So this was a group of patients in an OA cohort. They had basically symptomatic and X-ray proven knee osteoarthritis. And what they did was they looked at what things might have been predictive of a response comparing other things, but this was a post hoc look. So as for instance, acetaminophen and NSAIDs did better than using narcotics. No surprise because narcotics are used later line when these drugs fail. Being older, looking in 10-year increments, seemed to interestingly have a better response than being younger. And that was on WOMAC pain in a multivariate analysis. They also found some other things. High WOMAC pain with sensitization syndrome, so where the pain had gone more widespread, did more poorly. Whereas if you were looking at a clinical trial, if you have high pain, you should get a delta of improvement by regression to the mean, say on placebo or a placebo effect, but you should also get a treatment response. But in this case, high pain did worse, probably because lower pain has a better chance of being improved when you're looking post hoc. So what can we take home? I think the gene therapy for knee intra-articular injection seems really neat. I think we still have a ways to go on outcome measurements and finding the right drugs for symptomatic knee OA. Please follow me at Janet Bordeaux and of course following At Room Now. Thank you.